So this is session 2 for this morning, and I've given you an overview on the antiretroviral therapy a while ago. So we'll talk about short-term and long-term effects of ART, and this would be the common side effects of antiretroviral drugs. The discussion points for this talk would be a quick rundown of the short-term and long-term effects of antiretroviral drugs that are in our HIV pipeline under the DOH program. Also, how to monitor toxicity in terms of laboratory testing and switching ART. So what are the factors that would predispose individuals to adverse effects of ART? This would include concomitant use of medications with overlapping and additive toxicities, not just ARTs, but with other medications that the patient might be taking, including supplements and other medications. Also, presence of comorbid conditions that would increase the risk of adverse effects like history of allergy, or baka naman mataas talaga yung cholesterol niya, or mahina naman talaga yung kidneys niya right from the start. Pre-existing conditions like diabetes, hypertension, liver disease, kidney disease, also drug-drug interactions, and genetic predisposition. I brought this table back. This is from the last session because, again, I'd like you to be familiar with the common medications or with the medications, with the ARBs that are in our HIV program. And these are the medications that we will discuss individually kung ano yung mga common side effects. And I decided to present this session in such a way na maintindihan natin yung side effects per drug, per antiretroviral drug. But let's go first with their class. So with regard to the nucleoside reverse transcriptase inhibitors, the NRTI, as a class, as a group of antiretroviral medications, ang hallmark ng toxicity ng NRTIs would be mitochondrial toxicity. So alam naman natin na mitochondria is the power plant, the energy generating part ng ating cell. And once it is affected, several conditions might ensue. One is lactic acidosis, and this is the hallmark toxicity of NRTIs. And when you have lactic acidosis, or patients have lactic acidosis or high lactate levels in the blood, patient might present with GI symptoms, lethargy, tachycardia, tachypnea. Other hallmark of mitochondrial toxicity would be peripheral neuropathy, myopathy, cardiomyopathy, pancreatitis, lipoatrophy, and hepatic steatosis. However, our current NRTIs that are in our pipeline would have very low risk for this kind of toxicities, and that includes the abacavir, emtricitabine, lamivudine, and the tenofovir, both TAF and TDF. So yung toxicity ng or the mitochondrial toxicity, very common yan sa mga old NRTIs like your stavudine, na hindi na part ng ating program, didanosine, hindi din part ng ating program, pero common din ito sa zidovudine, which is still part of the program. Now, individually, for the NRTIs, abacavir, ang common adverse event associated with abacavir is hypersensitivity reaction. Kaya nga, screening for HLA-B5701 is recommended before starting abacavir. But is it available in the country, this kind of screening test? I don't think so. And the risk naman of hypersensitivity to abacavir because of being positive to HLA-B5701 among Filipinos is very, very low because common ito sa mga Caucasians. Actually, yung study dito is between Caucasian and the Black. Mas common sa Caucasians more than the Black. And I don't think mayroon study on among Asians. Also associated with abacavir is increased risk of hyperlipidemia and cardiovascular events. That's why it is avoided among individuals with risk for cardiovascular events. Emtricitabine and lamivudine For lamivudine, the common adverse event, or if not the an adverse event that is associated with lamivudine, although it's rare, is pancreatitis. Incidence lang niya is around 0.3%. For emtricitabine, 2% of patients receiving emtricitabine would present or would experience hyperpigmentation ng palms and or soles. Again, the emtricitabine is part of the program because it is combined with tenofovir sa ating PrEP, but not sa ating antiretroviral treatment. For tenofovir, tenofovir is very, very notorious for causing kidney injury. So it is associated with Fanconi syndrome, and recently we have had a lot of patients experiencing Fanconi syndrome because of tenofovir. Patient would usually present with elevated creatinine, low phosphorus, and low potassium, serum potassium. They also present with glucose in the urine in the absence of diabetes mellitus. That's why tenofovir is avoided if your creatinine clearance or EGFR is less than 60. Like what I said, there are two types of tenofovir in the country: the tenofovir diproxyl fumarate, which is what is being used in our ART, and the tenofovir alafenamide fumarate. In the country, tenofovir alafenamide fumarate is available, but this is for hepatitis B. But between TAF and TDF, mas less yung renal toxicity and bone toxicity with TAF compared to TDF. Another adverse event associated with tenofovir is bone loss or pagbaba ng bone mineral density, and it is seen in 6%. The 6% here is the 6% drop in the bone mineral density, and it puts the patient at risk for osteomalacia. However, this bone loss become stable with continued use of tenofovir. So hindi naman ganun alarming ang bone loss and osteomalacia if tenofovir is part of your treatment regimen. Weight gain is also associated with tenofovir, but this is more associated with your TAF rather than your TDF. For Cydovidine, this is no longer our first line, but for patients given Cydovidine, headache, malacia, anorexia, nausea, vomiting, lactic acidosis, and loss of lymph fat or lipoatrophy are the common adverse events. Very notorious ang Cydovidine sa bone marrow suppression. And a classic hematologic problem associated with Cydovidine would be a macrocytic anemia. Sometimes patients will present with leukopenia and neutropenia. Very, very rare, or if not, it does not occur at all, ang thrombocytopenia with Cydovidine. Before, when Cydovidine was still being used as a first line, we monitor CBC regularly if the patient is on Cydovidine. But remember, this is a dose-limiting toxicity. But whether anemia can be corrected or not, or whether anemia will progress with Cydovidine, that would be a decision to make whether to change Cydovidine or not. For NNRTIs, there are no specific class-related adverse events associated with NNRTIs, but the two most commonly used, this should be NNRTI, would be neurologic and psychiatric side effects. For efavirenz, efavirenz is associated with prolonged QT interval. That's why it is avoided in patients who have the risk for torsade de pointes or arrhythmia. Efavirenz is also associated with elevated hepatic transaminases, including fulminant hepatitis. So it's best to monitor your ALT, AST, especially in patients with moderate to severe liver disease, those with a Child-Pugh score of B or C. Very, very notorious ang efavirenz sa neuropsychiatric side effects. Patients will complain of nightmares, impaired concentration, hallucination, irritability, and depression. At ito yung side effect ng LTE or particularly efavirenz, specifically for efavirenz, na lagi kong sinasabi sa pasyente when I'm going to start a patient on efavirenz containing regimen. The neuropsychiatric effects, the possibility that the patient will complain of dizziness or headache after taking the drugs. But I also tell them that this side effects is not a long-term side effect. If your body gets adapted to this side effects, then your body will be able to overcome the side effects eventually. Another issue with efavirenz is the long-term mental health consequences and increased suicidality, especially among those who have the risk, or especially among those who have mental health problems. So generally, the recommendation is to avoid efavirenz in patients with psychiatric illness, and those with genetic predisposition, because recent evidences have shown na hindi naman lahat ng patients taking efavirenz nagkakaroon ng psychiatric problems. Hindi lahat ng pasyente na nagtitake ng efavirenz nagpapakamatay. Hindi lahat na nagtitake ng efavirenz ay nagiging bangenge eventually. But what the evidences are now showing is that there are patients na may genetic predisposition sa gantong mga psychiatric illnesses, and these patients should not be given efavirenz containing regimen. For the neuropsychiatric effects like the nightmares, hallucinations, irritability, depressions na mad lang naman or not really causing so much problem, what advice can you give to these patients? And one advice is to advise them to take efavirenz on an empty stomach, because this may reduce the risk of these side effects, since yung high-fat diet and high-caloric meals can increase the absorption of efavirenz. Although efavirenz may be taken with or without food, but to lessen the side effect, advise patient to take it on an empty stomach. Efavirenz can also cause an increase in your lipids, in your cholesterol, and I think this is the side effect that is associated doon, or that is presented doon sa ating case kanina. However, the increase in lipids, a good thing is it's not associated with increased risk for MI. But I'll discuss later what to do if there is an increase in your cholesterol if the patient is taking an antiretroviral regimen containing efavirenz. For nevirapine, although it's no longer part of our first line medication for adults and adolescents, nevirapine is associated with hepatic necrosis, especially among those patients with liver problem, and those patients with very high CD4, especially among those treatment naive. So it is avoided in patients with this should be liver disease, those with Child-Pugh score of B or C. Very, very notorious ang nevirapine sa serious cutaneous reaction. And we've seen a lot of patients, around 40%, 50% of patients taking nevirapine, developing Stevens-Johnson syndrome or toxic epidermal necrolysis. So watch out for any hypersensitivity reaction if the patient will be started on nevirapine. But the risk factor for hypersensitivity reaction would be if the patient is a woman or a person has higher CD4 cell count, more than 250. For rilpivirine, the most common side effect is depression, insomnia, headache, and rash. But it has, comparing to efavirenz, it actually has lower neurologic and psychiatric adverse events. So that's why if the patient is on efavirenz and okay pa yung kaniyang intake ng NNRTI, and the patient complains of this, neurologic and psychiatric events because of efavirenz, rilpivirine is also a good option. Now, rilpivirine is also associated with prolonged QT interval, so there's the risk of arrhythmia. So avoid this medication in patients with risk for torsades de pointes. Now let's go to the INSTI, the integrase inhibitor. As a class, all INSTI integrase inhibitor medications are associated with increased weight gain. Insomnia and dizziness can also occur in some patients, and rarely depression, suicidal ideation, elevation of your CPK enzymes, rhabdomyolysis, and myopathy may also be seen. Again, these are rare. But for the integrase inhibitor, ang pinaka-common talaga na side effect, but not necessarily life-threatening, would be weight gain. And this is a comparison of the different integrase inhibitors and NNRTIs and PIs, showing na mataas talaga yung changes or mas malaki yung changes in weight if the patient is being given integrase inhibitors compared to your NNRTI and protease inhibitor. Pero among the integrase inhibitors, dolutegravir is the most commonly implicated integrase inhibitor na nagko-cause ng weight gain. I'm not sure if it's a bad effect or it's a good effect, but definitely may mga pasyente tayo na ayaw tumaba. But for dolutegravir, the serious adverse event that we should monitor actually is that elevation in creatinine. But what's good here is that even though merong increase in creatinine, it doesn't mean that there is a reduction in the kidney function. So in giving dolutegravir, we expect a small increase in serum creatinine. Napakababa nga 0.1 to 0.2. So it's not really a cause for an alarm pag nag-increase ng creatinine because of dolutegravir. Mas implicated ang tenofovir sa kidney injury than dolutegravir. Now, 3 to 15% of patients receiving dolutegravir will complain of insomnia and dizziness. And this occurs significantly more frequently in females and those patients more than 60 years of age. Now, for protease inhibitor, there are several side effects that appear to be a PI class effect, while others are agent-specific. But the class side effects would include insulin resistance, hyperglycemia, diabetes, hyperlipidemia, lipodystrophy, hepatotoxicity, bleeding in patients with hemophilia, and prolonged PR interval causing arrhythmia. Adverse reactions can also be a result of drug-drug interactions with other hepatically metabolized drugs. For lopirito, the common side effect is still GI. So 14 to 24% would complain of diarrhea, and 2 to 6% will complain of nausea. You may give antidiarrheal agents if the patient presents or complains of diarrhea because of lopinavir, ritonavir. Now, mas implicated ang lopinavir, ritonavir na mag-cause ng hyperlipidemia, elevated in your total cholesterols, LDLs, and triglycerides. 20 to 40% of patients will have hyperlipidemia if the patient is on lopirito. And there is an increased risk of myocardial infarction. Compared to efavirenz or NNRTI, merong risk for hyperlipidemia, but the risk for myocardial infarction is very low with efavirenz. So hence, if patient is on lopirito, you monitor the patient's lipid profile. Another side effect of lopirito is hyperglycemia and insulin resistance, which puts the patient at risk for developing diabetes mellitus. That's why we need to monitor also the fasting blood sugar and HbA1c if the patient is on lopirito. So in a nutshell, lopirito has a lot of side effects, GI and metabolic, increase in cholesterol and increase in blood sugar. This is from the United States guideline from Clinical Info. And these are the laboratories that we need to perform upon ART initiation. This is on the second column. And after several weeks to several months, these are the follow-up laboratories. But if we go to our admin order, to our local guidelines, these are the minimum. Again, I'd like to emphasize the minimum laboratory tests in monitoring ART toxicity. For tenofovir-containing regimen, we monitor serum creatinine within 6 months of initiation, then every 12 months. For efavirenz-containing regimen, we monitor the lipid profile within 6 months from ART initiation, then every 12 months or as needed. For zidovudine-containing regimen, we monitor the CBC at 2, 4, 8, 12, 24 weeks after starting the regimen, then every 6 months or as needed. And for PI-containing regimen, we monitor the lipid profile and the fasting blood sugar within 6 months, then every 12 months or as needed. Now, when do we switch ART? Because the patient is developing adverse effects to the antiretroviral regimen that we're giving. Remember that we modify ART in patients with ART-associated treatment-limiting toxicities. If the toxicity or the adverse event is life-threatening, we immediately discontinue all ARTs and reinitiate an alternative regimen without and this regimen should not have an overlapping toxicity. But if the toxicities are not life-threatening, umakyat lang naman yung cholesterol or nagkaroon ng konting rash, this can be managed by substituting another ART for the presumed causative agent without interrupting treatment. Other chronic, non-life-threatening adverse events like dyslipidemia or increase in cholesterol can be addressed either by ART switching or wag mong i-switch ang ART, wag mong palitan ng ART, pero manage the adverse event with pharmacological or non-pharmacological intervention. Either mag-add ka ng anti-cholesterol or advise patient na low cholesterol diet or exercise as part of the non-pharmacologic intervention. And most importantly, individualize your management strategies. It's not a one-size-fits-all. Hindi lahat ng pasyente ay pare-pareho, hindi lahat ng ART ay pare-pareho, at hindi natin i-expect na ang side effect ng ART sa isang pasyente ay pareho ng side effect sa ibang pasyente. Now, my take-home meds. ART can help people with HIV live longer, healthier lives, and reduce the risk of HIV transmission. But ART can also sometimes cause side effects which are manageable, but a few can be life-threatening. Overall, the benefits of ART outweigh the risk of side effects. There are newer generation of ART like dolutegravir that can cause fewer side effects. And hopefully we'll be able to have in the future antiretroviral therapy that are very effective and also very safe. Now, different ARTs can cause different side effects. People taking the same ART can have different side effects. Again, individualize your treatment.